I'd like to welcome everyone to today's webinar presentation, Process and Space Planning, Efficiency Through Innovation. Too often, perceived healthcare facility needs are solved by adding more space and investing more in resource infrastructure. Physical space is just one aspect of how a facility performs. The other and often more important aspect is process. For decades, facility planning consultants have appropriately listened to clinical, medical, and administrative users describe how they do things, and with intuition based on benchmarks and experience, planning options ultimately responded to supporting those processes. As a result, this has been more akin to a slow evolution of planning trends than an innovative engineering of healing environments. Integrating process improvement analysis into the facility planning effort is critical to developing value-based facility planning options. Utilizing data, process mapping, and simulation models to understand the existing state, the planning team can apply variables to the models when constructing the process simulation, resulting in new data, predictive evidence for future state performance improvement. The presenters will offer recent case studies to illustrate the approach described above, including the goals and objectives of the initial planning project scope, the process improvement techniques applied to the planning effort, and the operational results. Before we introduce today's speaker, let's go over a few details about the webinar. It is 90 minutes in length. The first 60 minutes of the program is presentation, followed by a 30-minute question and answer period. Also, today's program is being recorded and will be available on the NESHS members-only portion of the website a few weeks after the session. Please note that you, as attendees of the session, are participating in listen-only mode, but can interact with the speaker and me, the moderator, by using the questions pane located within your webinar management toolbar, which should be appearing on the right side of your screen. If you have questions during the session, please just type them into the questions pane and send them to us, and we will address them verbally at the end of the formal program. If time does not allow us to answer all of your questions will be forwarded on to the speaker, who will get back to you with those answers via email after the session. Also, during this presentation, you will be asked to participate in some polling questions, and we hope that you will partake of this measurement tool. As you exit the webinar, you will receive an electronic survey that we hope you will take a minute to complete so that we may measure your satisfaction level regarding today's program. Your feedback is very important to us. Everyone should have received a copy of the session handouts, and NESHS members should also have received a copy of the registration list in the hope that you will network with each other on this topic after the session. I would like to take this opportunity to thank our program Gold sponsors: ECG Management Consultants, Levi & Wong Design Associates, Market Decisions, MSI, PricewaterhouseCoopers. And now, it is my pleasure to introduce today's speakers. Steve Clayman is a Vice President of Lavallee Brensinger Architects. He has focused his career on healthcare architecture and planning, completing projects throughout New England. Mr. Clayman leads the firm's Process Space Group, which with specialized expertise in process analysis, simulation, and lean healthcare. He has an ACHA professional and holds a lean certificate. Welcome, Steve. Our second speaker today is W. Keith Davis, AIA, Lead, AP, and Lavallee Brensinger Architects, who has, over the past 20 years, developed an approach to healthcare planning and design that focuses on delivering clear, creative responses that are sensitive to hospital, patient, and provider needs. Central to this focus is a common understanding of clients' strategic goals that generate the need for any specific project. Through effective communications, Keith offers appropriate tactical planning options in support of the defined goals. Welcome, Keith.
Thanks, Roger. And just for a clarification, it's Lavallee, Brensinger architect. And
I apologize.
Let's hope I can be effective in my communication.
Yeah. Thanks, Keith. Well, we are looking forward to your presentation, so why don't you just jump right in?
Thank you, Roger. This is Steve. We would like to start our presentation with a recap, a quick summary of what we're going to be talking about today, and about how to create innovation through process and planning. And the first thing is a little storyline of that we want to ask you. This is not one of the polling questions, but does this sound familiar? You have your patients that love you and appreciate the care, but they don't want to wait. You've got a staff that's dedicated, but they just don't feel that they have the space to work. You've got the technology that's always growing and expanding, but there's no room for it. A campus that's got 1 million square feet and no room. Then you have administration that's always telling you that money is tight. There's no more capital. Facilities is maxed. They don't have the resources for another project. So you've got a problem, and it's a problem common to all healthcare facilities and becoming even more common in these days of financial restraints. So do you add more space? Do you relocate? Do you cram in more into the space that you have, or do you just make do? I think that's part of our presentation today. Do you really need more space? So rather than guessing, which is often the root of many projects, we'd like to explore the idea of really researching it, analyzing, and getting into the core reasons for a space problem. So we think that every project should start off with a research phase, and I'm sure many of you do this, but often it doesn't include the design team, and it's not done on a facilities basis. So there's information available on wait times, utilization, staffing, volume, scheduling, and duration that should inform what you need. Then that can be used to further develop a current state, diagramming out what's happening in your existing facility. And then taking that potentially to the next level with detailed simulations. The one that you're seeing on the screen right now is a simulation of a registration area. Actually, this was at UMass, and the task was pretty simple. No money for construction, but they had a problem, and they were also adding new steps in the registration process. So could we solve it without actually building anything? And the answer was yes, but you had to know where you started and what was causing the problems. So simulation is a great way of understanding what's going on. And then taking that information, charting it out, recapping it, and putting it in a presentable form, so essentially you know your basis, what the problem is, and where you're starting from. So with that research, you can then begin to explore your options. And these options could include the use of multi-use spaces, as we'll talk about later on in the presentation. Hospitals probably are one of the few industries or healthcare where major resources sit idle for a substantial portion of the day. And we feel that there's many opportunities for spaces to have multiple uses so that they don't sit idle. I'm sure many of you walk around your facilities, look indoors, and see empty rooms. The simulation that's running in front of you is a study that demonstrated to a hospital that by combining their prep and their recovery functions into one room, they can significantly save space and get more capacity. So once you begin to understand the basis of your operations, you can begin to chart out things and see how they affect your operations. We're a big proponent, and we think this just makes perfect sense to incorporate lean into the planning process, not as something that's applied to an existing department only. And then look at your schedule. Time is the fourth dimension, and it has a huge impact on how space is utilized. So with this information, you can develop an understanding, you can start to develop solutions, and then find opportunities for your projects before you get committed.
Okay, so it's time for our first polling question. And the question is, does this indeed sound familiar to you? Would exploring all options help define the need for a project? Please select one. Definitely, some of the time, never. Okay. So I see about half of you have voted. We're waiting for a few more until we can move on. We're at the 65–70% mark. I just asked the speaker, in your experience, when you come to the client, how often have they done some of the baseline sort of upfront assumption gathering that you need to do your work?
Actually, often it's done at a very high strategic level, but not, it's rarely done sort of at a more departmental level. We find that the needs are often defined by intuition and personal experience, which is valid, but isn't the only metric.
And Roger, generally, if there's a champion in the system or at the even at the departmental level, some of this has begun, but it hasn't become standard, I would say, at this point.
Okay, so we have a great response now with over 3/4 of the people responding. Here are the results. Does this indeed sound familiar to you? Would exploring all options help define the need for a project? Well, we have 69% of the people saying definitely, and 31% saying some of the time. Do those responses surprise you, or do they sound kind of normal to you?
I think that's encouraging, that it's recognized that this information would be of value, and that's what we'll be talking about, how other facilities have used this information to improve their projects and making them more efficient.
And just in the nature of our question of does this sound familiar, I think it's certainly not surprising.
Yeah. Okay, thanks. Okay, so let's continue with the presentation.
All right, well, and this is Keith talking now. And looking at the registration list today, the introduction I'm going to give you prior to Steve launching into some case studies is going to offer very little new information, but it's helpful to set the context of how and why we've developed this approach. Roger, as you mentioned earlier, as healthcare architects, we've always appropriately listened to and learned from the clinical and organizational staff, turning our observations and interviews into spaces and really effectively institutionalizing their current behaviors. Before that even begins, forces outside of the traditional scope of what we do have often been defined and defined the facility solution as well as the operational solution before we ever even have the opportunity sometimes to meet the health systems planning team. There's many times a budget before a program is even written that's been decided upon. Rather than evidence, benchmarks and existing workflows are used in defining the potential project, and clinical input based on current state operations, again, albeit necessary and required, it becomes the basis of future planning. And as Steve said, intuition and personal preferences sometimes build a momentum and sometimes are championed by a strong personality on the systems planning team that, again, sometimes substitute for a real discovery process and evidence. As well, during the documentation phase, traditionally, the input from the clinical staff oftentimes gets severely diminished, and the design team goes off and prepares their construction documents, and construction begins. And I'll be a little self-critical here, but with minimal exceptions, effectively what we've done is reinforce the current state. We may have done it at a larger scale and with new finishes, but that oftentimes is the result. So as we move from the traditional process into the innovation process on slide 6, basically what this graphic is trying to suggest is just a continual communication loop. Discovery. It requires you initially to strategically kind of remove the preconceptions that we all approach every project with. It generally isn't some grand aha moment. It kind of develops over time, comes to light through investigating and challenging people, so it needs to be a very open process. Certain criteria may be specific and unchangeable. The budget comes to mind again. But the level of understanding relative to how the planning responds to those criteria allow for a more transparent and strategic response rather than a reaction to those criteria that may not be able to change. And obviously what underlies or is a blanket over all this is our communication tools that help communicate everything that I just suggested needs to occur during this innovation process. Several tools, and we'll talk about these in the case studies, but several tools that support this continuous information loop, as I called it, focus on visualization. We'll talk about simulation modeling, as Steve referred to, and 3D visualization, which can also be included in building information modeling, which is what BIM is for those who don't live in the architectural or space planning world. They really help to translate the data and into a visual form as we're talking about space planning. The planning effort, in this process that we've described becomes very inclusive. We called kind of an innovation process generates this reformed result. This graphic is just meant to be something to look at while I talk about what we call generating predictive evidence. It's database knowledge that increases the confidence of how a space will perform. As Steve mentioned earlier, it's not always analyzed, sometimes it is, but not always analyzing existing conditions, but trying to create new spaces and to trying to create some predictive evidence that will help forecast how that space might work. So these tools for innovation, as we say here, that we've introduced will be, and we'll be talking about more in the case studies, are, as you see on the screen, data mining as early as possible. Many times during the programming process, asking for volumes and data that is available to us earlier on doesn't get inserted in the project till later. So taking a very deliberate early data mining exercise and data creation, as I said, in the case where there aren't existing data. Schedule analysis. What we're talking about there really is space utilization. There are very, very few other resources that a health system is going to let sit dormant. Staff, equipment, money, that those don't normally sit without some aspect of utilization being defined for them. For some reason, space does, as Steve mentioned earlier, and I think we'll talk about in some of these case studies how that can be addressed. And again, I've already talked about the simulations and the visualization aspect of communication and bringing technology in very, very early, whether that is someone in-house to the system, whether that's a consultant that we can bring to bear on the project, or vendors. Technology can offer, as all of you know, many solutions that don't require space responses at all. So this lean process improvement that I've just introduced, again, is nothing new to any of you listening in. But as we say here, don't accept the status quo. It's very important to understand the status quo and the effects that it has on the process. So it's not disrespecting the status quo. It's not accepting it. Is what we're talking about here.
So I'd like to start reviewing one of our 3 case studies that we're going to present today. In each of these case studies, I think will support the beginning of this presentation. So the first one is Concord Hospital's intervention suite, cardiac intervention. The hospitals had the need for a new EP lab. They had a cath lab that was out of date. And the ideal was to locate the new EP lab within their existing intervention suite. The problem that they were currently dealing with is their front end, the prep side of things, was limiting the throughput on some very expensive equipment and the utilization also of their staff. So they were spending more time transporting patients and getting patients prepped because they didn't have sufficient space. And that also resulted in potential delays in the procedures. And as you know, once you get delays in the system, then it results in wait times, and you've got some very expensive equipment and people hanging around and waiting. So on your left portion of the screen is a map of the unit in the floor, and the interventional cardiology unit shared a wing of the hospital with the AM admit unit. And AM admit is basically morning admits for the surgical department. These would be people that will be going to surgery but returning to a private room at the end of the surgery, likely, or discharged at the end of the day. The floor was a former patient floor, as you can see by the layout. So the AM admit unit occupied a significant portion of the floor and was perceived as a busy unit. So given these issues, the traditional solutions, and these were solutions or issues that came up as we studied the project that the hospital was sort of already pondering. Do we relocate the cardiac program? That would cost millions and be extremely disruptive. And what would it displace? Do we restrict the patient throughput to match the facilities? Not an ideal use when you're talking about such expensive. Do we relocate AMU? The problem was where. This happened to be an ideal location because the surgical suite was right across the hallway. Or there was even consideration of deferring the whole project until they had a larger project that they could do in addition to the hospital. So the scenarios that we developed with the hospital in a very interactive process was how can we maximize the use of their existing resources by breaking down the departmental barriers? And could the staff of the AMU deal with the prep activities for the cardiology unit? Essentially, could we merge the volume of the two departments so that we could use the spaces together? So what you see on the left side is a cardiology unit that actually grew to get some dedicated recovery space, but a block of space which is brown, which is a shared recovery space. So we had to make the case. We had to convince the staff and the physicians and the department leaders that this was viable. So we compiled the data. We looked at when patients arrive and when they leave, their type of patients, where they go afterwards, where they're coming from, and we created a simulation with this information, and then we were able to basically make the case that this was not crazy and that it could work without minimal impact. So some of the information, we call this sort of data mining, was readily available. On the right, you'll see a lot of little numbers, but basically this was information that was extracted from the hospital system with very little additional, actually no additional data gathering on the cardiology side. AM admits didn't have the same level of detail, so the staff put sign-up sheets outside of every room, and every time a patient came in, they locked it in, and when they left, and we used that to build a model or a data set for the AMU. And then we merged the data together, and we differentiated patient types, but we essentially created a schedule that was based upon the schedules of those two departments. So we didn't make any attempt to really change when the patients were arriving. That could be fine-tuned later, but to look at it just in the current state. And then we developed the simulation. You're going to see a movie now which shows exactly how this floor was predicted to operate as a shared department. And the little red people are the AMU patients, and the blue people are the cath lab patients. And we're hoping that the cath lab patients don't turn blue. What it began to show was that there's very little utilization super early in the morning. This is running on the timeline, so this is like 6, 7 o'clock in the morning. But that as the day wore on, the department started to fill up. And the big concern was, would AMU be forced into using their rooms as semi-privates in order to achieve this merger? And what we were able to show that you'll see pretty soon now as the department is filling up is that that did happen, but it happened very rarely, and that's only after we increased the volume in our simulation significantly beyond where the volume was now. So we were able to demonstrate and show staff and the physicians that this is a doable process. So they were able to move ahead on this basis. So what were the results? We demonstrated that additional space was not needed if the department activities were merged, that AMU could lose one room for cardiac use, and that double occupancy rooms usage was minimal. So when we do these studies and we present this, often we're asked, have you ever tested your simulation against reality? And this is a case where the unit has been operational for 18 months, relatively recent, and we were able to compare it to how it's operating to how the simulation ran, speaking with the department director and looking at their numbers. So in general, the room utilization matched the simulation model. They do have occasional semi-private usage, which they're not happy about, but recognize as a necessary evil during until they can do a major project. That the volume has grown way ahead of the projections, which is why they're seeing the semi-private room usage. But that's very occasional. And the most interesting thing I found is that their utilization of their cath lab and their EP lab is now between 87 to 97%. So you've got these very expensive resources that are no longer constrained by the front end, and they are working essentially 100% of the time within their scheduled allotment. So often we're asked, is doing these studies expensive? How, we can't afford it. We only have a design budget that's already set. And we did this hourly. And usually we don't share fees all the time, but just to put this in context, I think our total fees were about $3,000 to do these simulation studies. What it saved the hospital was potentially millions of dollars. And I think that's a pretty good investment on your money. So our next case study is completely different. It is a brand new building rather than an existing building, and but it had its own set of challenges, and it had a different kind of innovation required than the case study that you just saw. This is Dartmouth Hitchcock's new medical office building. It's a 3-story building located on a brand new site. And you think, brand new site, we can do anything. But the issue was that this building came with approvals already attached to it. So we had a fixed footprint, a fixed site plan, and a fixed building area. The hospital, the medical center, wanted this to be a model of a medical home for primary care. So with those challenges, we began to look at the traditional solutions. It was accommodating multiple practices, as many medical office buildings do. And initially, each one of those practices was looked at as a standalone, which is sort of the common way of doing it. Each one is your separate client. And the result was that there was was no cohesive, there was no opportunities for sharing, and each practice had a different operational model. So the medical center really wanted all their primary care together, and which we felt made perfect sense. So the only way to get that to fit on one floor was to reconsider the traditional locations of some of the spaces that go with primary care practices, primarily the non-clinical spaces of doctors' offices and administrative spaces. And essentially what we did was all those spaces went on the third floor of the project. And the primary care floor, the entrance floor of the building, basically had just clinical space. There's no ancillary space on the floor at all, just the spaces that are needed to support a primary care practice. And it does a lot of things. The biggest thing that it does is it allows the departments to be designed in a manner that promotes efficiency by sharing resources, and also allows for more flexibility as departments change. And in the spirit of the medical home, it allows for more sharing of resources, not only by staff, but by patients. So we developed a simulation for the whole building to test how the configuration would work, what the travel distances were like, because it was a different model, and how the teams worked inside of that. And this was helpful in terms of visualizing the whole operation of a building. Unlike many other industries, when we design a space, you're designing it for the first time. It's a one-off, and you can't really test how it's going to work in the real world. And we find that using these simulations is a great way of predicting the operation of the building and informing the users and the clients. So this is a simulation movie, and you can see that there's, again, similar to the other one that you just saw, we have little patients running around the floor plan. We also, it may be difficult to see, but we also have caregivers. And in this case, the model is based on what we call resource-driven simulation, where the caregivers are actually driving the model. So the patients are being brought to their exam rooms. They don't move unless a step is completed by a caregiver, such as an exam or vitals. And then we're tracking how long it takes for the patients and the staff to walk between all their various tasks. And we're also looking at the room utilization. If you look at the lower portion of the screen, you'll see it's telling you how many rooms are available at any given point during the day. And you can see that often there's numerous rooms. And it also gives you a pretty good snapshot of the intensity of the utilization. Now, of course, this was based upon their move-in numbers, not their projection numbers. But it did make them feel a lot more comfortable that they had the room to grow and expand within the existing space. The other thing that was important in the design, not necessarily related to the simulation, but the whole layout was based on a module of team rooms and exam rooms. And the team rooms were intended to house the physicians and practitioners and support staff, MAs, and nurses in one collaborative environment that also supported the medical home model. But they were all designed to be identical. So even though there's 4 practice groups that this was designed for, any one of them could locate another space, and that the growth between them was seamless. Another important feature in the programming of this was demonstrating the importance of not assigning exam rooms to a particular practitioner, but rather to a group. And that allowed the highest utilization of the resources because spaces weren't sitting idle. And that gets back into the issue of time and scheduling. And we also tested the ability to do common registration. That was a difficult issue to tackle in terms of how many, if we're merging all these practices, what would we need for a central registration area if they chose to go in that direction. And we're going to just spend a second longer here, but it's interesting to just see what data was being collected as these simulations were running. And this was travel distances. And we went, in our next slide, we'll be talking in more detail about the analysis of travel distances. So that issue that we talked about in the beginning of where the physician offices was not surprisingly an important issue to the practitioners and the physicians because it was different than they're used to. So one of the things that we did was we developed a very detailed analysis of what the impact of location had on the physician's travel time and efficiency. And we did a simulation of just one of the team rooms. And the options that we looked at was A, the private office scenario, where the private offices were at the end of the quarter, similar to what Dartmouth has in some of their other facilities, and the exam rooms are in the middle, and the practitioner goes back to their exam room, back to their office, and does their charting documentation, and they come back and see patients. A centralized work area, team room, and then we also developed a model where we said, what would it be helpful if they had little touchdown spaces in between each of the exam rooms to utilize between patients. So we charted all that out, and the result was pretty dramatic. The dark blue line that you see in this document, in this chart, is if the physicians traveled back to their offices, how much time would they travel? The left axis, the vertical axis, indicates distance, and the horizontal x-axis indicates the time of the day. And the blue indicated that they would travel over 2,000 feet a day to go back and forth between their offices, between patients. The green indicates that they're going back to a team room, and then the red indicates that occasionally they're touching down between exam rooms, as well as primarily using the team room as their documentation. So we were pretty effectively able to demonstrate that this model actually reduced the travel time of physician spends during the course of their day by 50%, and that was very
Steve, do you want to mention how this document was used? Because as we know, changing culture is often a part of this process.
Right. So initially, the simulation didn't grow out of this particular issue. We kind of took this on as ourselves. But once the charts were developed, every time there was pushback on the office locations, I think this chart was probably pulled out and sent to the physicians to say, look, now this is a significant change in your efficiency over the course of a day. Do you really want offices in the traditional manner? And I think it was very useful in convincing them. And it's nothing like data, charts, and facts to make a case rather than intuition. So I believe, oh, I'm sorry, one more slide. So the current status, the project nears completion. It's going to be occupied in a few months. There was some institutional challenges, as there are in every project that we work on, particularly as you're merging multiple practices together. The most encouraging thing, though, is even though the project hasn't begun operation, that several of the departments that we talked with have already begun to merge. And they're able to do that without one architectural change to the plan. The plan's flexibility of being modular and using the same layout for each of the department has already paid off because it's given them the ability to shuffle departments and merge departments without having to invest money in the architecture in the building. Traditionally, the sledgehammers would be coming out and walls would be coming down. But in this case, it's just been seamless. I think we're going to pause now for some a question, a polling.
Correct. Thank you. So the second polling question is your organization currently considering developing your primary care practices on a medical home model? Please select one. Definitely, some of the time, never. So, you know, one of the things I'm interested in, because this is kind of an emerging model for primary care, is there some kind of emerging industry standard when it comes to space planning for patient-centered medical homes? Or in your experience at Lavallee, Brensinger, is it more of on a case-by-case basis and everyone's different?
I think that, you know, we certainly see trends developing, and one of the trends is that there are a lot of systems developing new primary care facilities. There are many of those in our office right now. And in doing that, it's kind of like what I was saying earlier, we have to guard ourselves from approaching these with a lot of preconceived notions prior to actually going through the deliberate process of programming and planning for each client. Having said that, certainly in similar programs there are space planning elements that have become, for lack of a better word, a trend. Key to the medical home model is obviously a collaborative approach, and the team room certainly supports that, and the team room's proximity to the exam room corridors support that.
Sure, makes a lot of sense. Excuse me, sorry for interrupting, but I just want to encourage attendees to vote. We've only got about half of you who have voted on this particular question. We like to see at least 65+%, so please cast your votes. Thank you. I'm sorry, I interrupted. I think it was Steve. Did I?
Well, it was Keith, but you know, I think that you know, there are many elements that are system and sometimes site-specific, like registration process. Steve talked about developing a central reg process at Dartmouth Hitchcock. That is in play for some clients, not in others. But I think most of the, as you ask about trends that we have seen or been part of developing, have to do with the clinical model.
I think one of the common questions, the most common questions that comes up, Roger, is how many exam rooms to provide per practitioner.
I see.
And there's a lot of rules of thumb, but we have found that really testing it with running a simulation is a good way of confirming whether the intuition of the practitioners and the managers is correct. And often we've been able to save a lot of money by demonstrating that you really don't need 3 exam rooms per practitioner, that you're just moving the patients from waiting in the waiting room to waiting in the exam room.
Well, one of the elements that was in the movie about the Dartmouth Hitchcock medical office building, looking at the whole building, exposed that. And then, Steve, I mean, it exposed that the limitation wasn't the number of rooms, it was the practitioner utilization and the number of practitioners.
Sure. All right, thanks. So now we have results of our poll. Is your organization currently considering developing your primary care practices on a medical home model? And over half the people, 57%, said definitely, and 43% said some of the time, and nobody said never. So what about those results? Are those kind of consistent with your experience, Keith and Steve?
Yeah, well, as I just mentioned a minute ago, we have several clients with a capital S, several who are looking at developing these models, whether it's in new facilities or in existing facilities, and start to implement just some of the, and I think it's very important to implement the process. It doesn't mean you need to go into building new facilities to start to implement the procedures and the process within the system.
It was certainly one of the challenges that I know that all of our participants or guests are aware of, is that the reimbursement system has not caught up with the intent of the medical home and of a collaborative, results-driven healthcare. And I am guessing that that is part of the the reason why everybody hasn't gone into this, and it is still a relatively new model. So
what I thought was fascinating is that it seemed like you developed some economies of scale because you had designed the space for 4 identical PCMH layouts, and it seemed like, if I understood you correctly, that when there was a full space in one of the sort of pods, if I can call it that, a provider could utilize another identical space. Are there sort of economies when you sort of have several co-located?
Yeah, absolutely. And that is one of the things on the Dartmouth plan, and something that we try to incorporate, is creating a lot of cross connections, and unfortunately sometimes that produces more circulation space, but that's paid off in the ability to get from one side to the other and utilize space more efficiently. The traditional model used to be that Dr. Jones would have their 3 exam rooms for the day, and it didn't matter whether he used 3 exam rooms, but they were his 3. They were set up for him. Everything was where he knew they would be. He had decorations in them.
Sure.
And the problem is that that's just a really poor use of resources. So we look at it and encourage our clients to look at it as a pool of resources rather than dedicated resources.
Makes sense. Okay, so let's continue with the presentation.
Okay, we have one last case study. Again, this one is completely different than the previous 2 with different issues. We are currently in the process of creating a new emergency department for St. Joseph's Hospital in Nashua, New Hampshire. It's a 30-year-old facility, hasn't been renovated in 30 years. It's outdated. It's no longer meets the needs of the patients with privacy. There's not enough room for the clinical staff. The rooms are extremely small in some of the rooms. It was developed over time. A fast-track unit was added to try to help the department spread its load, but the problem was it was not integrated. So they had difficulty running it with their resources, and that was largely driven by a very irregular building plan. One of the constraints was the emergency room had to stay where it was in terms of how it fit on the site with ambulance access. There was no other room on the campus, and there was no money available to create an addition. A long time ago, we had looked at an addition to the hospital for their emergency room, but it was considered not financially viable. And all of this led to longer than ideal patient stays, although we're going to dive into that in more detail. So the traditional solution to this might have been to expand the building, which I just mentioned. We did study that probably 5 years ago with St. Joseph's. To make the department as big as possible based upon staff perceptions and preferences. And then in the meantime, replicating what they're doing in the new setting. I think just to touch on the staff preferences, I don't want anyone to feel like these are whimsicals. The staff have their experience and knowledge is the most important information on planning any project, but sometimes it's hard for them to see it in context of a year or long term. They're in the trenches and they're dealing with their patients. So their perception of being just incredibly busy and not having enough space might have been based upon 1 hour out of the day, 1 day out of the month. And the rest of the time, this space probably has enough capacity. So one of the things that we try to deal with is making sure that everybody understands when they're hitting capacity, what the duration of it is, and is there any way of shifting that. Now, obviously, in an emergency department, you don't control when your patients come in. So you have to be flexible in terms of how you accommodate that. So we looked at some scenarios that would accomplish what they wanted, but could fit within the existing footprint without substantial change, and achieve a much more efficient ED. So the first thing we did is we looked at all the spaces around the ED and what was non-clinical, and determined the highest and best use for all the spaces. Then even on the clinical side, we looked at, with a hospital, what spaces were being utilized to their best level. Were there spaces that were underutilized? Could they be merged or shared? We went through the data for the department. That was very informative in terms of giving us an idea of how long the patients were in the department, and comparing that to industry benchmarks. And then we developed, as you'll see in a minute, a simulation of the proposed program. And we also began a 2P process as part of the design process. So the findings were that we could get 2,000 square feet of contiguous space by relocating some underused departments in non-clinical spaces like documentation and insurance, and move those to other areas of the campus. That there are some differences in perceived use of the space. But you can see on the left was their existing plan, and on the right is the proposed plan, where we've got a much more regular block, and we had a very, very minimal addition to just accommodate a new entrance. So how did we do this, and where did we look for the information? All the information was available in the hospital systems, working with their informatics people to develop, to extract it and make it into a meaningful format that we could use, tracking things like average minutes to triage, average minutes to seen by a physician. And then we ran a simulation of, built the simulation of a very simple concept based upon the program that would fit into the space. And this is the simulation that you're going to see. And what was really interesting is, and this is, we kind of almost put the whole project on design on hold at this point, was that with this program and applying all of the information and timing that they currently use, in other words, this didn't include any changes in performance or operation, that the department would fill up, and many of the same things that they're complaining about now would happen in the new department after they spent millions of dollars on the new facility. Clearly, it would be a much nicer facility. The rooms would be better. There would be privacy. But there would still be backups in the department, and there was still times where there would be waits in the waiting room, and that just didn't seem appropriate. So we talked to the client, and we said, this is a perfect opportunity to invest in a lean process improvement. Why? We showed them the simulation. We said, we're just going to replicate what you have, as I just mentioned. Why not use this as an opportunity? We have a little bit of time before we have to really get going here to step back and look at how you provide care within your facility. So we, on a very short notice, we put together a 2P process of planning and process improvement, and we established in a half-a-day meeting, actually less than a half-a-day meeting, sort of where the bottlenecks were with their department. We had about 30 people in the room. And then we created this diagram, which looks crazy, but basically it's demonstrating how the patients move through the department and how staff and resources take care of the patients. And the little red starbursts are problem areas, areas where there's bottlenecks or that there's complaints or there's concerns. We documented this, got it out to everybody, got it back to the staff. They looked it over. We had another meeting. We refined it. Then we had a follow-up meeting where we basically said, okay, what can we do to begin to fix this? We knew that it's such a short duration that we wouldn't be able to fix everything, but there was some things that through the design process and technology, we did have all the technology people in the room, we could clean up a lot of the problems. Now, Keith often points out that these slides don't look a lot different, but if you studied them in detail, you'd see that there's probably about 20 stars that have gone away.
And those that did not really serve to expose problems within the hospital-wide system that can then be investigated. You know, what you were addressing here, Steve, is, you know, the ED issues in the process. Obviously, we always discover those issues are often brought about by weak systems in other departments or functions, and that's what this leads to.
Yeah, and it would be naive to think that in a course of 3 or 4 3-hour meetings that you'd solve all the problems and have a perfectly functioning department. But what we're able to do is make a significant dent in how, primarily on the patient arrival and rooming side, things were fixed. And this is a work in process. We're working with them now on studying the impact of the admittance timing for patients going into an inpatient bed and how it impacts the overall flow of the department. So what's the current status? The project is advancing. We're going to start construction in December. We actually have a bid package going out next week for some of the pre-work to relocate those departments in spaces that were not considered essential, that would free up space for the emergency department itself. It was a great process. We had a really collaborative staff that were dedicated to the whole concept of process improvement, as well as, you know, stepping back and looking at the design and recognizing where the problems were. Several of the lean improvements have already been tested and implemented. Some of them were in the works before we started, and I've already begun to help them with their process of admitting patients in their waiting room. And as we said, we'll cover down the line, is that lean is a continuous process. It doesn't just happen in these meetings and then you go away and all is good. That you have to continuously work on process improvement. But what it did do is it allowed us to design a space that was better informed than it would have been if we just basically sat down and asked the users, what do you want? And it also gave the users the impetus to correct or to improve the way they work and realize how they compared to other hospitals in terms of their throughput and where the opportunities were. One of the other things we wanted to mention as part of the process that really was instrumental in the detail development of it was the extensive use of mock-up rooms. We built numerous mock-up rooms, and unique to this one was that we built them quickly and almost in place with the hospital so that we can test things in real time in terms of moving a cabinet, moving gases with the staff there. And it really helped to inform the process and promote efficiency, I think, in the long run. So we're going to do a poll now, and I'm going to turn it back over to Roger.
All right, thanks. Our third poll: does your organization incorporate lean and process improvement as part of initial project planning? Please select one: definitely, some of the time, never. I'm so fascinated by the way you use simulation, and I think it's one of the top of mind questions from our audience is what software are you using for that kind of function as you use it for planning?
We are often asked that question. There's several software packages out there. The one that we use, and we've been using it for about 10 years now almost, it's hard to believe, but is called SimCAD, and it was developed originally for manufacturing, and it's still actually, I would think that a significant portion of their work is still manufacturing, but it really works for any process-driven activity. I don't want to compare healthcare to manufacturing, but healthcare and manufacturing share many common features of throughput processing.
Thanks. SimCAD. Okay, we've got about half of you who voted. I'd like to encourage more to answer the poll. And when you're doing your simulations, I noticed that early on, one of your case studies, there was incredibly efficient usage of space, somewhere between like 87 and 98% efficient use of space. Is there a target that you use to get to so that you hedge against sort of overutilization or somehow under capacity as a final result?
Well, historically there certainly have been, and I think that goes back to some of the goals and criteria of the specific system. This obviously works towards understanding maximum utilization in some cases of existing spaces and some of new planned spaces, and it's meant to make that an informed decision about whether a utilization rate wants to be closer to 80% and handle some variations in the projections and that type of thing. Steve, I don't know if you have other info on that, but certainly, when you look at in the 90% utilization, on the one hand, great utilization of your space, but on the other hand, very little flexibility for projection fluctuations.
Exactly. Okay, so we have the results of our poll. Our third poll: does your organization incorporate lean and process improvement as part of initial project planning? The results are 25% said definitely, 63% said some of the time, and 13% said never.
Yeah, I think that is not surprising either. Again, looking at the list of people who are listening in today and participating in this, I think that actually I might have expected to see a little higher on the definitely bar. But and obviously the sampling is different than if we went out and sampled, the health systems at large, I think.
I think this is actually the reason why we're doing this presentation today, and why we think it's important to reach out to the healthcare industry and our clients to say that you're missing an opportunity. This is what I always tell my clients. Building a project is a huge opportunity to do things right. And it's sort of like everybody's expecting change, so this is a time when you can actually implement change.
Okay, so let's continue with the presentation.
All right. Well, this we'll wrap it up, and I don't need to reiterate what we said probably at least a couple times during the process, other than to point out, the integration of this process to space planning. We don't forget that we are healthcare architects, and the fact that we've included this and integrated this into our space planning process has allowed us to move it up in the planning process, which I think is critical, which is also mentioned up here. I think discovering the solutions, talking about the environment of care, as much as we architects may or may not want to admit it, very few patient survey comments are about how beautiful or the spaces are. It's about how well the staff performed. It's about how quickly they received their service. And I think we need to recognize that, and we do. And so the environment of care, which includes the staff, creating spaces that are efficient and pleasant for the staff to work in, is critical application of this. And again, just starting early, starting this dialogue before programming, before budgeting, if possible. This can be applied very, very early, and should be. Steve, I don't know if you had anything else you'd like to say.
I think one of the things that we have discovered over the years, and that has given us the impetus to take this approach, is that often too many decisions are made before we get involved, and it makes it very difficult to be flexible and efficient in the development or the definition of a project, that expectations are already set either on budget or what the project is going to include. And we feel that it should be done in a more informed environment so that everybody's sort of coming along with the same level of detail and developing it. Keith mentioned earlier feedback loops where we provide information to management, administration, the users, and they consider it and get back to us. And it's a real dialogue rather than here's a set of parameters that we want to accomplish. You have to do this for $20 million, and it needs an atrium in the middle of it. And we're going to get 4 exam rooms per practitioner because that's what we promised Dr. Jones.
I think momentum, sorry to interrupt, Steve, but I think momentum is an important and positive thing generally when we talk about it. It can also be an impediment to the right kind of progress.
Exactly. So I think that concludes our presentation. I hope we did this on the right amount of time, and we're open to questions.
Yes, Steve and Keith, you absolutely did do it on the right amount of time, and I'm sure our webinar audience joins me in thanking you for sharing all these great insights with us. A reminder, too, to the audience that if you have a question you'd like to submit, you may still do so. Just type it into the question and answer pane on the right of your screen at any time. We will answer as many as we can get to in the time we have. So our first question is, what tools do you use to compile data when a facility does not have the ability to mine the data themselves?
That's a great question. We can't start from zero, but often when we do these studies and simulations, it's not uncommon to spend 50% of the time in building the simulation in extracting the data that we need and getting it into a format that actually is usable. Because the systems that capture this are not thinking that they're capturing it for us. They're capturing it for regulatory agencies. They're capturing it for billing purposes, a variety of other things. So generally what we do is we either get the data in an Excel format or a database format because those are easy for them to export out to. And then we convert it into, typically into Excel, although we've used Access databases. And then we begin to, I like to use the term cook the numbers, but that would indicate that we change the numbers. What we try to do is we need to get it into the same minute, same format of minutes, times of days of start, so that everything is consistent. We have to ask a lot of questions to make sure that we're interpreting the data correctly, because it might actually be indicating something that is not at all pertinent to what we're doing.
And over the course of several and many of these, we've developed some forms that we provide our clients that offer them a chance to do a little bit of mining on their own, information we know they have, but distill it into the format and just the things we're looking for, really. So we have created, just within the office here, a set of questionnaires and forms that lead them through their own aspect of data mining.
And just one last thing along those lines. Well, actually, two things. One is that if you don't have the information, you can get it a lot of times, but it does require dedication of some resources. And usually, I think all the times where we requested information that the client doesn't have, they have assigned an FTE to gather the information with a clipboard and a watch and monitor when patients come and go. And the final thing is that the old adage, garbage in, garbage out. if we're not using good data, then the results won't be accurate. So it does require some real sort of common sense approach to this, to making sure that the numbers we've got and the data that we have is useful.
And not to beat this one to death, but I may have discounted observation earlier. But that certainly is a key part of this as well. You can't not exclude the observation of existing processes where they do exist, and interviews with the staff. So it's a myriad of resources. Some the data is in the right format. Others has to be created.
I noticed in your simulations you're often driving them off of very precise historical data. At what point do forecasts come into the process?
Well,
forecast of utilization.
Right. That's a great question. There's two ways that we do simulations. One of them is that we take the information that we have, like on the Concord Hospital one, and we actually use the exact times for the exact patients. So in other words, we build a simulation based upon historical data with no interpolation. And that becomes our base model. And then from there we literally insert patients into the model individually. So it wasn't that it's two departments, it's a course of a day, so actually adding patients at different times of the day is easy to do. Other models, like the Dartmouth one, are based on averages and variables. And what we have been doing more and more is building variables into the simulations. In other words, how long does it take for vitals to be done by an MA, rather than making that a fixed number for the simulation. We will make it a variable so that we can test the impact of changes to that. And everything becomes a variable other than things like walking times, which is we use as a fixed. We don't want people to run to improve the efficiency of a plan. But how long it takes a physician to do their initial exam. These are all things that we input as variables. And our first test on this is we will build, if it's an existing department, we will build a simulation of the existing conditions first. And then we run that with the department there, and we can basically confirm, is this the way you work? And we can look at when patients leave the department, how long it took them to be processed through the simulation, how does that compare to their actual, and then that gives us sort of a solid start for modifying and adding patients. And then adding the patients is often just a change in a variable of in the timing, and then you can begin to look at almost on the fly what happens when you add more patients to a facility.
Interesting, thanks. Okay, the next question from the audience is, lean was brought up a lot. Do you find there are many or any local New England trainings for this healthcare type of lean training?
Yeah, I think probably one great source is the Massachusetts Hospital Association has been doing lean classes about every quarter, or 2 or 3 times a year.
Yeah, a couple times a year, I think.
And,
which is what you...
yeah, which is what I took. And that's led by GBMP, which is one of the nation's leading lean trainers and consultants that are located in the Boston area. And they did a fantastic job, and they are really have set the bar for implementation. The interesting thing is, just like the simulation software, their basis was manufacturing, which they still do a fair amount of, but they are also heavily involved in healthcare now.
Thank you. Next question. Lean has been taking a while to take hold in the healthcare industry. What do you do to win over the skeptics at your clients? Does the skepticism mostly come from those who have never seen it?
Well, it's a great question. And, you know, over the years there's been other things. There was, what was the continuous quality improvement?
Yeah.
And there was other sort of buzzwords that all the hospitals jumped onto, and then they gradually faded out. I think what is making lean more acceptable into healthcare is, first of all, is the driver that it needs to happen. That healthcare institutions are recognizing that they have to be as efficient as possible. Sometimes I think the word lean is overused, and it could be replaced with common sense. But the lean process gives you a framework to tackle some of these issues. So I guess the best way that I think is to have them talk to their peers at other hospitals that have implemented it and get the results. There is a organization that both Keith and I belong to, the Massachusetts Lean Hospital Networking Group. They meet every other month in the Boston area generally, and it's free, and it's a very open discussion. But what they always generally include are case studies from hospitals that are involved in lean, and their presentations are often quite impressive in terms of what they've done with their process and their throughput and their changes and the patient experience. And an important part of lean is documenting the results. It's one thing to make a change, think it works better, but unless you can go back and say, it used to take us 10 minutes to do this task, and now with these improvements we can do it in 5, and be able to document that, it's hard to convince people. So I guess that would be my answer.
Okay. The next question from the audience: did Dartmouth Hitchcock go to central registration for the entire building? Why or why not? What about the peak registration times of 8 a.m. and 1 p.m.?
Well, that's a great question. And the interesting thing is that in the end they did not go to central registration. They went to quasi-central registration, I would guess is the way I would put it. But they did not go to central registration for the primary care practices. They were very concerned about the visibility of the waiting areas from the registration position, and it was so radically different than the way these practices behave now. So the plan that you saw was actually a progress plan and ultimately did not. But the question on peak was, that was the real reason for the simulation, was to see what happens at peak times. That simulation was run with patient arrivals based upon their actual patient arrival times. We could adjust that, but it basically showed what happens when you get peaks in the length of the queue, and that drove the number of workstations. But as we showed in quickly, the one simulation for UMass Worcester, in that clinic, they had a terrible peak problem because everybody arrived at the same time, and they had multiple practices merged together. And that simulation was very insightful for helping them understand what was causing their long lines down the corridor.
Roger, I think that's going to be one of the things that, or at least it interests us here quite a bit, is the developments in the registration process, the technology that can be applied to it to mitigate that. And with all technologies, the kind of the time it takes to implement those from the user, from the patient side, and get comfortable with the new process, because it is the first step of their process in engaging with the health system. But I think that that's going to be something that continues to develop, and certainly haven't seen, you asked earlier about trends, haven't seen a predominant trend except that everyone starts off thinking central reg and ends up modifying it in some way, in our experience so far.
Yeah, I think part of this is, as your listeners probably would agree, is really part of the whole transition of the healthcare industry. There's clearly some very nice things about having decentralized registration, and every time you go to the doctor's office, it's, Mrs. Smith is the one who greets you at the door. The reality of it is that that's a very inefficient way of working, and I'm not sure that we can afford that anymore. I think that's a decision that healthcare providers have to balance as they're moving forward, is the staffing and efficiency. I don't think you have to compromise it, but I think you have to say that you can't do things the way you always did them.
The patient-centered or patient-focused approach. So the answer is probably somewhere between a very absolute central registration and, in the case of primary care, self-rooming. I don't, at the two ends of the extreme.
And then you mix into that self-check-in kiosks, which often come up, and I think will become an important part of the registration process.
Great. Next question is, I'm wondering whether everything in your models are quantifiable. And I shouldn't say models, I should say processes, because recognizing that efficiency is probably the most important thing with everyone's eye on the bottom line, and the need to reduce healthcare costs being such a paramount goal for most organizations, there is that other goal of being patient-centered and having a healing environment. And I wonder, beyond talking to the physicians and the providers around what their preferences are, how do you get input on those softer concepts that may be more patient-centered?
I think it's a great question, too. We've said that about most of the questions here, haven't we? I think that a lot of this can't be replaced by just getting focus groups and getting patient survey results and understanding and putting some priority on that patient-centered approach. An interesting result of a focus group for another large multi-specialty facility that I was working on. We had a patient focus group provide some answers to some questions, and they were considering using those little vibrating coasters you get at restaurants when you go to wait for your table and you generally go have a beverage or something while you're waiting. We proposed using those so patients could feel comfortable freely moving through the waiting room. If they wanted to go sit in this quality of space to work on their laptop while they were waiting for their appointment, if they wanted to sit in the family or children area, they could do that and not feel like they had to be visually connected to that check-in counter or that access to the clinics. First thing we heard was, "You've got to be kidding me," from the patients. They said, "The first thing you're going to tell me when I come to your clinic is, here, wait." So something that sounded like a great idea was not very, what we thought was patient-focused was not very. So I think that, all of this analysis needs to include qualitative analysis as well as all of this data-driven quantity.
Yeah, I think the part of that answer is focus groups. Part of it is common sense, not putting aside your own personal experiences and that of the caregivers, of what they experience when, in the case of primary care, when they go to the doctor's office. And often there is information like Press Ganey reports that give you an idea of what patients like and what they don't like about a particular facility or department. But it is really important that we don't, in all the data and the number crunching and all that we don't lose track of that we have to provide an environment that is supportive to both the patient and the caregiver. I would close with it. I would think that one of the biggest dissatisfiers for patient experience is waiting and doing things multiple times and being inefficient, that they perceive that they're being inefficient, like filling out the same form multiple times or at being asked for the same information at multiple times. That is often one of the #1 complaints on Press Ganey reports. And that is all a part of efficiency. So if you make it efficient for the staff to provide care, you're going to make it efficient for the patient to receive care, and they're going to appreciate that.
Thank you. Okay, so there's 5 minutes left, and we have time for one more question from the audience, and that is, do you consider self-rooming in your simulations?
Have we done that in the simulation?
We have not done self-rooming. The only project that I'm really aware of it being built is Virginia Mason Hospital out in Seattle. I got to tell you, I'm not convinced, but I would love to see it. We have a client who's actually going out there right now to take a look at it, so we can't wait to hear the reports. And that's a perfect case of experience versus efficiency. So I would love to know the results. I'd love to know of other places that are doing it.
We have had the discussion with several of our clients, but have not applied it in a simulation model, I guess is the short answer.
That's the simple answer. Love to do it.
Well, love to investigate it.
Yeah, love to investigate it.
Okay. All right, so I'd again like to thank Steve and Keith for sharing their expertise and insights with us, as well as everyone in the audience for setting aside 90 minutes of your day to listen to this webinar. This concludes today's program. Please take a moment to complete the electronic survey upon exiting of the program. We hope you'll join us for our other upcoming programs in the NESHS webinar series. Real Estate Inputs to the Healthcare Strategic Planning Process on October 18th. How to Build a Successful Career in Healthcare on November 15th. The Role and Value of Post-Acute Providers to ACOs on December 13th. Visit NESHS.org, that's NESHS.org, for more details or to register for a future session. And look for our webinar email invitations. Thanks, everyone, and have a great day.